Trigger digits have been classified into four stages. Grade 1, where the patient presents with only pain and A1 tenderness but no triggering. Grade 2 is where there is triggering which is voluntarily extendable. Grade 3 is where there is locking of the digit which is passively correctable. And finally, grade 4 where the patient presents with a locked digit which is uncorrectable. Sometimes one may come across a trigger finger with a very audible sound, like in this patient. Acute soft triggers can be treated with conservative management. However, one needs to rule out other conditions like tenosynovitis, in which case a sonography and further investigations may be advisable to find the cause. The various modalities of conservative treatment are warm water soaks and stretches to make sure that the flexors are gliding, limb elevation to reduce the swelling, mobilization, local ultrasonics, anti-inflammatory medications, and in some cases, local steroid injections. Now, what are the indications for a surgical intervention? Trigger digits that are unresponsive to conservative treatment, a locked trigger, patients that come with disabling symptoms that are hindering their day-to-day activities, and if there are other associated conditions like Dupuytren's contractures, tenosynovitis, or a ganglion cyst. The surgical release is done preferably under local anesthesia with a tourniquet or volant. Once the local anesthetic is instilled, the patient is asked to actively trigger the finger while the surgeon palpates and localizes the area of the trigger. Now, how do we localize the A1 pulley? The A1 pulley lies at the level of the metacarpophalangeal joint enveloping the flexor tendons. A simple way to identify it clinically is to follow the distal palmar crease, that is in line with the metacarpophalangeal joint. The digital neurovascular bundles course vertically on either side of the A1 pulley. So the best way to avoid injuring them is to carry out the dissection along the center of the digit. Once the A1 pulley is identified, we then look for the junction between the A1 pulley and the flexor tendon and start incising the A1 vertically along the center in line with the flexors. Excising a part of the A1 pulley has shown to have reduced risks of scarring, flexor tendon adhesions, and recurrence of trigger, and therefore avoiding post-operative complications. Here is a picture of a thick A1 pulley that has been excised after the release. Once the A1 pulley is released and excised, the FDS and the FDP are delivered individually and checked for proximal and distal excursion and any adhesions between the two which may be addressed at the same time. Now when it comes to the thumb, the orientation of the ulnar neurovascular bundle changes vastly with the position of the thumb, as is very clearly seen in this video. Trigger digits may sometimes present with other conditions as well, like this one where the patient presented with a locked trigger with early Dupuytren's cords. In such cases, a vertical incision may be beneficial in addressing the pre-tendinous cords and excising them, along with the release of the A1 pulley. This patient presented with a trigger associated with a ganglion cyst over the A1 pulley. This can be diagnosed with a thorough clinical examination and further investigations like an MRI, like in this case, or a well-performed ultrasound study. Here, the ganglion was excised and the A1 pulley was released. In cases of tenosynovitis, an intraoperative ultrasound may help in identifying the extent of the pathology, like in this patient where an additional incision was made distally to excise the hypertrophic synovium. Once the trigger digit is released, the patient is asked to actively flex and extend the finger to confirm the completeness of the A1 pulley release and to ensure that there is no triggering. Isolated trigger digits are routine and with some experience, they are straightforward to deal with surgically. One must be aware of the associated conditions that may require additional surgical steps to achieve a good postoperative outcome.